So it made me curious for those of you in the audience, and I just want to say what a huge privilege it is to be here today, and thank you all for the opportunity to speak with you and at the Emeritus College, and a place I hope to reside someday, not too distant future. Um, but for a person who trained in infectious diseases and microbiology, and I started out my research career in virology and molecular biology to talk about aging, and in particular aging in its relationship to infections. But hopefully we'll walk through at least my perspective on aging from an ID lens, and we'll see if we can arrive at some conclusions. My disclosures, although nothing directly related, and paid on salary by these companies, but they have sponsored some of our research.
Finding ourselves needed to be careful about staying balanced and all of that. Anyway, I got home and I said, you know, we need to really address this, and looked into what we for years had read about in terms of the benefits of the practice of Tai Chi, an ancient Chinese discipline. And for 2 years now, we've done this. But specific to the topic of today, as soon as we began this journey, and it is a journey, we quickly discovered that it's a practice that invests deeply in the trio of mind, body, and spirit. And I have to say that after 2 years of training, I've gotten to know this and the benefit of it a little bit, but I am so looking forward today to learning more about the importance of thinking as we age, trying to address all three of these areas of great importance for all of us: mind, body, and spirit. So I'm very glad to introduce Dr. Marconi today. Joined Emory in 2009. He is Emory University Professor of Medicine in the Division of Infectious Diseases, also Professor of Global Health at Rollins School of Public Health, Director of the Infectious Disease Research Program at the Atlanta VA, staff physician at the VA Infectious Disease Clinic and the Grady Ponce Clinic, which together serve over 8,000 people with HIV. And in addition, for over 20 years, he's enjoyed a very deep research relationship, collaboration with colleagues in Durban, South Africa. Received his BS in microbiology and cell science from University of Florida, MD from Johns Hopkins, completed his clinical and research training in internal medicine and infectious disease at the Brigham and Women's Hospital and Massachusetts General. Served in the U.S. Air Force from 2005 to 2009, where he was director of the HIV Medical Evaluation Unit and Research Program in San Antonio. It's really a great pleasure, both on behalf of the Emeritus College, but also personally, for the privilege of introducing Dr. Marconi today. Vince?
So because Dr. Gaines is in the audience, I need to share a historical vignette here, at least a quote from Rudolf Virchow, who in many ways is sort of the father or one of the fathers of pathology. And he said, if I could live my life over again, I would devote it to proving that germs seek their natural habitat, diseased tissue, rather than being the cause of diseased tissue. For example, mosquitoes seek stagnant water, but do not cause the pool to become stagnant. It's an interesting quote, and certainly there's a lot of relevance to what we do in infectious disease, a concept called locus minoris resistentiae, where there's an area of lowered resistance or least resistance that tend to be where infections arise. And I think if I were to rewrite the quote, it would be much more awkward and difficult to say. But I would say if infections, actually seek the natural habitat for them, that habitat which is shaped both by genetics, so it's inherited, but also by the experiences, the life course of an individual, are really what predisposes an individual to the disease after the infection. And then that infection itself feeds back onto that tissue, okay, causes changes, mostly through the immune system, that then change the way you age through the rest of your life and the subsequent infections thereafter. So it's this to and fro of predisposed tissue and predisposed immune system when it meets with the infection that then predetermines how your aging process is going to go, what we refer to as the life course. So I want to start out first by acknowledging the many individuals who died during the pandemic. And although the first thing that comes to mind when we think about the pandemic is people who had a SARS-CoV-2 infection, developed COVID, and died often in the hospital. But there's a lot of others who, and these are colleagues of mine and Dr. Gaines and others in the room, all of these I worked with, who died in the first 3 or 4 years after the start of the pandemic and were ID doctors. Now, a number of them did die directly from having COVID, but there are others who died from other related situations, conditions, and things that we're going to talk about today. So this was a model that was published in 2022 that looked at not only COVID deaths over time directly related to COVID, but also in the blue, excess non-COVID deaths, and their cumulative deaths numerically in the top, the absolute number, and in the bottom figure is the rate of death per 100,000 people. And so these excess non-COVID deaths are the deaths beyond which we would have expected in seasonal averages over time for people, across the world globally. So as you can see, in the early stages, COVID really dominated the causes of death. But over time, there were excess numbers of deaths beyond what COVID accounted for alone here, as you can see over time. And this has continued to be the case in some models that have persisted afterwards. So the first question people might have is, what are they dying from? So what do you all think in the audience could be some of the reasons why there might have been more deaths than expected due to non-COVID causes?
Heart disease, cancer,
Why would those be greater?
inflammation of the arteries, cells decided to fly.
Okay, so that's a great question. So was it misattributed, or was it from non-COVID reasons that they died, meaning COVID had nothing to do with it at all?
We can't say that.
That's a difficult thing, right? It's hard to say. Now, these are people who had COVID not listed anywhere on their hospital admission, for example, or in their recent history. So that's where things can get a little bit tricky, but absolutely to your point. I think there's a question in the back.
So you, maybe secondary infections, bacterial infections from lung tissue that's not aerating well, since alpha COVID behaved differently than the current one does.
These are excellent. All of these are great points. And these are things that still an individual, if they had COVID when they were admitted to the hospital, they would not be counted as a non-COVID death. So it's not the primary cause of disease. It means it's completely unrelated, and that would be related to COVID. If that makes sense. So let me walk through a couple of reasons why. So one is, as we were talking about earlier, is underreporting COVID deaths. And this happened for a number of different reasons, some of which is just attribution issues, diagnostic limitations, right? There were also even some issues around people, refusing to admit COVID was the, reason that brought them in. There's all kinds of causes for that, and, insurance, et cetera, et cetera. But that's one particular or one possible reason. The other is hospitals were short-staffed and overburdened, right? So people coming in with things that they might have turned around and done okay, there isn't enough care that's available, right? There's not enough ventilators. We actually ran out of ventilators in certain places, right? We had shortages of nursing to be able to handle all the highly acute patients. So clearly that's a reason why we could see that. Also, poor access during the shutdowns to primary care is a critical reason. You mentioned cancer, for example. So a lot of cancer surveillance was kind of going by the wayside. And I show this figure from the Ponce Clinic where I work, one of the HIV clinics, to show the number of individual visits. And this is also kind of the viral load monitoring. It's the way we monitor patients, like a blood pressure for high blood, people with hypertension. And you can see immediately in early February or so, we had a decline of patients coming into clinic. The clinic was shut down, but it really didn't take that long for us to get back to some semblance of care. And as you can see, the lighter gray bars in the stacked bar chart represent the telephone and virtual clinics visits that we were able to hold. So we were able to kind of keep things going, and actually the monitoring didn't really fall for too long below the average. So that actually picked up. All of this to say that yes, there was an impact, especially early and even persisted down the road. A lot of patients were even lost to care. This wasn't completely the reason that we can't account for this. The fourth reason is long COVID, right? And so we're all familiar, we've heard of this. Some people believe in this entity, there are others that don't, but we'll talk a little bit about long COVID specifically and how that has contributed as well. And then pandemic stress. And this is very, very important, of which to say that even a few of the people in the pictures I showed you earlier, in fact, 3 of those individuals died directly because of that. Okay. And I don't need to get into the issues as to how this happened, but if you can imagine, there's a direct correlation as to how the stress impacted, and probably several of the others as well. So I'm going to focus on these 2 issues. First, I'm going to start with a couple of cases of individuals. The first is Barbara Nevins. She is a 59-year-old, she's a little bit older now, retail manager who was diagnosed by her neurologist after an exhaustive workup, found to have rapid onset dementia. This is someone who is highly productive. She was forced into early retirement and, has remained so to this day. So unable to be productive at the things she loves and enjoys, and is having a continued rapid decline in cognitive function. Then there's Alex Schell, and both of these you can look up, or were patients of my co-PI on this reverse long COVID study we're going to talk about. Had a 22-year-old Division I athlete from University of Tennessee who's expected to enter the upcoming Olympic trials, and it was a promising runner, long distance runner. And if you talk with him now, he literally cannot walk to the end of his driveway to pick up his mail. He's got such significant respiratory decline acutely after his COVID situation. Still hasn't improved. And the final individual I want to show you here was the wife of a friend and colleague of mine, Nick Guthey, who she was a screenwriter, 50 years old, was previously healthy, and she died of suicide after 13 months of debilitating pain from long COVID, was bedridden, had severe tremors, and horrible insomnia. We talked about sleep issues earlier. And so after everything she tried, all the possible medications and behavioral treatment, nothing worked for her, and left behind her husband, who's a writer and director as well, and a small child. And Nick worked with us on many of the NIH trials that were going on, helping us to pick, as a community member, appropriate therapy. And he literally spends his entire life talking people down from suicide all over the world who are trying desperately to manage their long COVID. So I mentioned a little bit about NIH engagements here at Emory, and I think it's important to realize we've focused very centrally to both acute COVID and long COVID. We're one of the major sites for Recover. This is NIH's large program that has observational and autopsy and various other clinical trial studies. At our site alone, called the Atlanta Hub, which involves Emory University, of course, the VA, Grady, Morehouse, and Kaiser, enrolled just close to 1,000 people on an ongoing long-term cohort. And the co-PIs here, Igo Fodekin and Xanthia Wiley, actually Igo became the national PI as well, so held some prominence from that perspective. But I want to start off first by thanking our community advisory board members who have been absolutely at the forefront, working with us closely all along the way. For those of us who worked in the field of HIV for several decades, it took a while for us to eventually open up to the idea of having such deep community engagement, of which we do now. But thankfully, long COVID, possibly because of those experiences, were right from the very beginning. In fact, the very first paper on long COVID was written by the patient-led consortium in May of 2020. So what is long COVID? Well, it's new or worse unexplained symptoms for 3 months or longer after a SARS-CoV-2 infection. And at least 40% of people have at least one long COVID symptom. They don't necessarily meet the full definition depending on how you write it. But 10% will have a score of 12 or greater, which is how the Recover Consortium had defined it at 6 months or longer. And that's the kind of classic definition that we're all used to. People with severe debilitation is much less common, around 5%. But when you consider the multiple 240 whatever millions of people who had long COVID, this becomes a considerable number who are affected one way or another. And in the US, close to 30 million, although the number is higher now. So what are the risk factors? And we can talk about this in more detail if there's interest. But it turns out there's a predilection for women, those of older age, severe infection, certainly the same things that we saw for acute COVID comorbidities, a socioeconomic divide, people with HIV, unvaccinated, and the older variants, especially Omicron, appear to be less significant, causing long COVID. So what are some of the unanswered questions right now? Well, for one, we don't have a really clear way to connect these phenotype clusters. As you can see here, there's sort of a cognitive cluster, cardiac, GI, sort of general one like the sarcopenia, pain, fatigue syndrome, pulmonary, and then low back pain. We don't have a good way of connecting those to biological mechanisms directly. And that would be a much nicer way, what we call endotypes, is to be able to connect these, and that allows us to have more targeted therapy. So right now, there's a lot more generalized therapeutic approaches rather than specific to the endotype. So that's one of the issues that we're trying to work on. The second is to improve our objective measures, either using things like cardiopulmonary testing, exercise testing, neurocognitive, and biomarkers that will help us more objectively identify people with long COVID. There are multiple mechanisms that are currently being studied, as I said, trying to see if we can connect those to these clusters in particular. And if you look at these, some of them were things that began during the acute infection. Others seem to persist afterwards. Some rely upon direct viral replication, others for just viral products that still are released, even if the virus no longer replicates. And some are just happening because the immune system becomes dysfunctional and then acts on its own, sometimes in an auto-mimicry fashion, like autoimmune diseases, where a protein that looked like the virus is actually on a protein of your own body. And so the immune system says, oh, there's a foreign invader, in fact, and then instead that's just a piece of cartilage in your knee. So that tends to be another cause of part of long COVID. And then there are other factors such as the microbiome being disrupted, microclotting cascades that were precipitated that cause blood vessels not to work, and oxidative stress as well, which is a key part of long COVID. And if you look at these things, these are actually the same kinds of hallmarks that we see in aging, right? So this is the key point I'm trying to show, the connection between the viral infection that SARS-CoV-2 is and these aging phenomena that we're going to talk a little bit more about. So they're the same hallmarks. And inflammation is only part of the story. It's one of the pillars, but as we talked about, there are other pillars of this, like macromolecular damage that happens, DNA damage, for example, protein disruptions, and then cells themselves. So we all know that cells, they replicate just normally when we produce new tissues. We're growing tissues, cellular turnover as they age. And every time cells turn over, a piece of the ends of the DNA get truncated, they fall off. And that's okay. We have lots of extra DNA that we don't need. But over time, that can start to lead to dysfunction, but it's a way of having sort of a molecular clock. Well, if you increase that replication because those cells are fighting infection or they're going off dysfunctionally turned on, you're going to increase that senescence process. So if you look at the aging paradigm, there's sort of kind of two key areas that are really at the center of not only responding to infections, but also to the aging process. And that's endocrine function, the sort of neuroendocrine pathways, our brain connected to hormones. And we'll talk a little bit about that in the stress response in a moment. And the immune system. And the immune system is absolutely at the critical intersection of all of what's going on in our body, responding to pathogens, responding to repair places that are injured, to tumors that are in the body, et cetera. And so it sits right at the center of both infections and the aging process. But let's talk a little bit about the normal stress response. So when all of us are living around in the room right now, I'm sitting out in front of, you're standing out in front of the audience, I'm intimidated. This audience is looking and glaring at these crazy things that I'm saying, and I'm going to face some tough questions like Dr. Gaines at the end. So all of these things are coming into me, right? So I'm getting visual, auditory, olfactory, sensory, gustatory inputs, right? Now, when I see things that come to me or feel or taste or sense something is a threat, that sets off a cascade of fight or flight responses. So heart rate increases, breathing, et cetera, fat, glucose. As you can see, one of these things is the immune system becomes suppressed during this time. And that all happens through that neuroendocrine pathway. The normal process is the threat's removed, right? The antelope gets away from the lion and it goes right back to drinking water, right? You see that all the time. If that were me, I'd be still running on to the next country, right? They just stop and they go back. That's part of the reason why stress is a major issue for humans and it's not for animals, right? Because we sit and think, well, gosh, if I just not gotten that leg out of the way, I'd have been grabbed and eaten, right? And we perseverate on that and we go over this, and that creates repeated traumas, and then we experience a new trauma, and then we have something, we exaggerate what the next trauma is going to be. So all of those things is what leads to more chronic situations of stress, as well as the actual real stressors that happen in people's lives. So Stephen Cole, and really an amazing researcher, and I encourage you to look up some of his work. He's at UCLA. Took a look at individuals, and this is a heat map for those of you not familiar reading these. Each one of these rows is a different participant, and each of these columns represents a different gene being, in this case, expressed. So this is RNA expression profile. And he looked at two groups. He looked at individuals who are isolated from their community, meaning they live on their own. They might be disconnected from their community, what have you, versus those who are well integrated, have a large social network, et cetera. And what he found, and this is a pretty dramatic heat map, you don't see it this kind of perfectly divided. Something that's green means it's turned on and red means it's turned off. Well, it turns out almost perfectly segregated. Genes of inflammation for people who are isolated are turned on, and if you're integrated, they're turned off. And then if you look at this other half, these genes include lots of antiviral mechanisms, including type 1 interferon, immunoglobulins. And for people who are isolated, these are turned off. People who are integrated, these are turned on. So what's going on here? Well, it turns out someone in extreme acute stress, there's a social environmental experience, gets interpreted as the brain as being a threat, and through that neuroendocrine and cell signal transduction pathway, proteins are turned on and some proteins are turned off in that fashion. And it turns out, and this has long since surpassed this number of different situations that he has studied, probably has tripled this by now. People in these various different kinds of stressful environments in their reality have that exact same pattern. And it turns out that these changes can be actually more than just temporary. They can actually be durable because of epigenetic changes. Now, epigenetic changes, as opposed to the ones where you just turn on proteins because of an acute change in your endocrine pathways, you are actually more permanently, not permanently, but more permanently, 3 months, 6 months, creating changes at the level of the DNA and promoter regions of DNA, turning them on or shutting them off based on, again, these same environmental stressors. And it turns out there was a study a number of years ago in 2017 that had been working in a community out west prior to an ice raid happened. And in those year time frame, they had all this data of the children, of the mothers, et cetera. And then they looked after the ice raid and found a traumatic change in birth weights and fetal abnormalities in the same Latino community after the ice raid. So again, showing how these things not only can be more durable, but can even get passed on from mother to child. So all of these kinds of things that I'm showing you here, people's diet, their psychological states, et cetera, can have impacts through a stress pathway. So Sunil Ahuja, who was actually one of my mentors when I was in San Antonio, looked at this from a specific immunologic perspective and said that there's basically these 4 patterns that come out for people prior to an infection, and that what these patterns are predict how you respond to COVID, how people respond to HIV, to influenza. Then he looked in the Framingham cardiovascular study. He looked in the Sardinia cohort, which is a cohort of centenarians that have been followed compared to those who are not in other communities. He's looked at child cohorts. All across the board, these same patterns show up. And basically, it shows people having either poor immune competence, which is essentially ineffective pathogen clearance, and high inflammation, which leads to end organ damage down the road, is the worst situation. And then you can imagine perfect immune competence and low inflammation is the best. And then in between those are the other 2 patterns that can be lumped together as kind of in between. And when he did modeling of this, you could see that individuals being at this perfect ideal state, which you would call maybe the youthful state, does the best, but can themselves, as I was saying at the beginning of the talk, experience even a decline temporarily during COVID. And where they rebound to after that predicts how they're going to do afterwards. Do they have more heart attacks? Do they have more strokes? To your point, do they have these experiences in the long run? And Monte Montano from the Pepper Center at Harvard and several of my colleagues, we wrote a paper taking a more holistic picture of this, that it's not just the immune system experiencing this, but actually all of our organ systems, whether it's the liver and kidney, the brain, the heart, et cetera, has this same reserve capacity. Some people start out at high levels, you experience an insult, and depending on how much that insult is and what your ability to push back or repair those insults predicts the way you go down the mountain from the top of the hill. And so people, for example, with HIV are more likely to have a greater, steeper decline in this because they have damaged immune systems, their heart, brain, lungs, et cetera, are going to be more impacted, and they roll much more quickly down the hill. So this is an important question because a lot of people ask during aging talks is, well, what can you do with this damage? Is there any ability to recover from this? If you do take a hit, how are people able to recover and get back to normal? What changes there? And it all has to do with this key question, is whether or not, for example, when people familiar with the heart, you have a healthy heart, you experience a heart attack, can you go back to the healthy heart, or do you go on to fibrosis and scarring and infarct? And that's sort of in between, whether you talk about stunning or hibernating or inflamed brain. We see the same in the brain with the penumbra around a stroke, right? You might have a stroke and you see friends come back and like, oh, they fully recovered. How does that happen? Others, they have continued stroke. The same happens with the lung, with fibrosis. Same was with a back injury, right? Why are some back injuries able to be repaired? And it all has to do with this concept of resilience, adaptation, plasticity, and remodeling. And so the key for us from a therapeutic perspective is there are both of these that we want to work on. We want people in that in-between who are still inflamed is get that inflammation to stop, bring them back to normal. Then with whatever has been damaged, what can we realistically do to bring that back to a normal state? Is that even possible to take fibrotic lung and bring it back to healthier lungs? So to summarize this part of the talk and then to talk about therapeutics, I want to give you this model and see what your thoughts on this. So there's our brain. We're basically just brains walking around the planet, right? We get exposed to something. If we see that thing as a threat, then inflammation levels go high, and then that leads to end organ disease. We become susceptible to infection, as I described, and autoimmune conditions. If we don't see something as a threat, then we remain competent immunologically, and ultimately we have less end organ disease and resistance to infection and increased longevity. So why does this happen? Teleologically, evolutionarily, why would this be the case? Well, it's believed to be that when we lived in small tribal units, most of the time in our life was calm, sitting around the fire, gathering fruits and nuts and berries, whatever the things. We lived at a fairly low stressful level. And during that time, what's the main threat that you have to worry about from a disease perspective?
Infection.
Yeah. What kinds of infections? Think about.
I mean, you could have a skin infection, you could break a bone, drink something from the water.
Yeah, so communicable is the bigger concern in that situation. You can get injured, no doubt, but the greater risk is a communicable disease, right? So respiratory infections, gastrointestinal infections. So in that case, you want your antiviral responses to be very high. You're not quite as worried about injuries, stabbings, and bloody stuff, where inflammatory responses tend to be better, tissue repair. However, once in a while, every so often, a month, couple of months, there is something that does require that, a stressful event, whether that's a hunt, whether that's a battle, whether you're running from a wild animal, right? Because you can fall, you can get gored, you can get stabbed. And so in those cases, when you're in that stressful event, you don't need to have an antiviral response to be active. You need to have more inflammatory responses to treat and take care of infectious problems along that course. But as a modern human, we've flipped that whole thing on its head. Right? we spend most of the time stressed. And then once in a while, we do something called a vacation, maybe a weekend, right? Where we drop that down. And for some individuals, that level of stress is even higher. And that's the point that Stephen Cole was showing, is people who live in microaggressions and chronic stressful situations tend to be much more likely to deal poorly with infections and have a more rapid aging process. So the goal would be to stop this, obviously. Ideally, we'd like to remove all the threats in the world. I'm not really very effective at that, especially right now. So where we practically work is how can we shift the immune system into a better paradigm to be more effective. So in long COVID, each of these mechanisms is targetable, okay? And we could walk through, we don't have to talk about each of these, but all along the way, the ones I was showing you about have numerous trials in multiple different classes trying to work at these various different areas. And then there are some that, like meditation, sleep, and exercise, are working at a more holistic level. And so this model that was originally used for talking about HIV, I use for talking about long COVID and actually aging in general. And this model is useful because the way that we target therapeutically makes a big difference into how effective we are in the long term. So the bottom, the roots here that I'm showing you are the various different causes of disease for us. And I'm just putting specifically some things like SARS-CoV-2, influenza, HIV, but toxins, there's many other things we're exposed to, food, drugs, et cetera, radiation. And there's also sort of the psychosocial issues we mentioned before that lead to stressors, right? Stigma, discrimination, poverty, isolation, et cetera. So these are kind of the environmental, psychosocial, infectious, and other problems that lead to disease as the roots. And then through the body, these key pathways that I was mentioning, neuroendocrine, immune, GI system, you get then ultimately manifestations along the aging hallmarks or aging pillars that I mentioned. And then, and unfortunately, I can't see the top there, but these are the kind of clusters of problems that you get, such as autoimmune diseases, cardiovascular disease, neurocognitive disease. So, sorry, that's getting that to move. But so interventions that we have focused on in my group is how can we address key choke points, such as those neuroendocrine processes, these key signaling pathways, and also how can we help on the psychosocial side to reduce stressors. Try it. Okay. So one such example of this are JAK inhibitors. So about 13, 14 years ago, Dr. Ray Shinazi and Christina Gavignano, who were members of the faculty here, started working on JAK inhibitors. They are infectious diseases research, but they looked at JAK inhibitors which treat people with rheumatoid arthritis, polycystic fibrosis, polycythemia vera, I'm looking at myelofibrosis, and all kinds of cancers. And they said, what's interesting about these particular inhibitors is they reduced a lot of the inflammatory cytokines that we also saw and see in people with HIV. And so because we know in HIV, these cytokines, these inflammatory mediators that come out during inflammation, cause all of these kind of end organ diseases, the aging process, neurocognitive effects, brain, lung, kidney. If we could lower that, then the rapid aging process that people with HIV have could be potentially slowed. So from their individual laboratory data that we looked at, we also found that it inhibited HIV replication, which is quite interesting. Somehow it was shifting that immune system from a high inflammatory process to an antiviral process. So with this in mind, we thought, let's test this in a population with HIV. So we actually took, and we could only take because of the FDA restrictions, a very, very healthy population of people with HIV. So these are individuals that were never allowed to have anything other than HIV, and high blood pressure was the only condition that was allowed. They had very, very high CD4 counts. Okay, so their immune system was pretty much normal. And by and large, most of these patients were fairly young. So this is not quite the population that you would really want to test this in because they're healthy to begin with, but that's where we started. And despite this, we were able to show you could reduce key immune dysregulatory markers in CD4 cells, we call immune activation, as well as inflammatory, these cytokines, these same cytokines we're talking about, and improve what looks like the viral reservoir in people with HIV. So we're having all of these same kinds of effects that we were seeing in the lab. So just about the time we were submitting this paper, the reports were coming out of China about this new disease. And we were hearing that they were having lots of these same inflammatory mediators, but in a much more exaggerated level in a much more shortened time course. And we said, is it possible we could use this same drug to treat people with acute AD? And at the time we proposed this, people said, oh gosh, don't do that. These people have a viral infection. Do not touch their immune system. This could kill them. And that's intimidating, hearing that from the NIH and from WHO and people who know better. But we said, let's keep looking into this. And in February, early February, this report came out of the UK, and it was an artificial intelligence screening of literally thousands and thousands of drugs, an in vitro library screen, or in silico library screen, they call this. And they looked at only inflammatory drugs, right? Anti-inflammatory immune modulators. And it turned out that of all of these drugs, one of them that worked the best and had the most action, not as an anti-inflammatory, but as an antiviral, because it looked at what proteins and things it's blocked and what proteins that the infection uses, was baricitinib, which is a JAK inhibitor, one that we were studying. So we said, okay, this is helpful. We don't think it's going to be a really great antiviral, but hey, at least that's a good justification to give to the NIH that it might actually help the antiviral process, but we need to cool down this inflammation because that's what's killing them. So we still didn't get anywhere. And we then said, well, we're going to try and do what we can to move forward. So this is Dr. Tatanji, who at the time was my fellow on the research side, but I was also on service with her in early March of 2020. And there was a patient that came in. He was 42 years old, previously healthy veteran, who had been out to New Orleans to see his mother for Jazz Festival or Mardi Gras. She unfortunately died from COVID. He came back and was very quickly brought to the emergency room, was sick, and started to die of COVID. His organs had shut down. He was on a ventilator, it was breathing for him. He needed support for his kidneys. He was in shock. He needed all kinds of blood pressure medication to keep his blood pressure up. He was dying. And I convened a meeting with our team, including at the time our division director, Dr. Farley, and others. And we said, based on the compelling evidence that we're seeing in multiple different areas, can we try? Nothing else was working. Can we try this drug in an open access, compassionate use where the patient knows full well the risks and agrees to it? And we did. And it turned out he was treated. This was a very short course of a relatively low dose. Shortly thereafter, his blood pressure improved, his heart rate improved, his fever went away, he came off the ventilator, and he ultimately went home. No requirements of oxygen. Now, this could clearly have happened because of the natural course of the disease, right? No way to know that because it's not a controlled trial. So we went on and did the same for 14 more patients and saw the same results. Now, we were encouraged not because these patients got better and walked out, but because we didn't make the situation worse. Now, I'm not a person who encourages doing single-arm trials, and I'm happy to talk more about this later. But I will say because of these data exclusively and that artificial intelligence study, we went on to do 6 trials around the world globally. The first one was Act 2 that we did in comparison to placebo with a background of remdesivir, an antiviral, and showed a statistically significant improvement in time to recovery. Then we compared the drug head-to-head in Act 4 to steroids. And it turned out that the efficacy with steroids was about the same, but the side effects was worse with the steroids than it was with the baricitinib. And one of those side effects was secondary infections, pulmonary secondary infections, as you mentioned earlier. And then we did a separate trial with Lilly supported with my colleague Wes Ely, where we showed this was the largest randomized placebo-controlled trial for patients with acute COVID that had ever been done and has ever been done. And we showed the largest reduction in mortality, over 50% reduction in mortality at 28 days for all causes. And we looked at this not only for people with severe hospitalization, including high flow oxygen, but also in people who were admitted to the ICU. And so the number needed to treat overall was 20. And for people who were admitted to the ICU was 6. So if you treated 6 people, you could get 1 person to survive out of the 6 compared to not. And so again, as I said, 6, and there's now been probably 25, I can't keep track of the studies that have supported baricitinib as being a key indication, included both in NIH guidelines, WHO, it's FDA approved, et cetera, repeating the same findings that we've had. So I say all this to show that this was acute COVID. And for us, when you look at long COVID, the same kinds of processes are also put in place. So we felt when you looked at all the different pathways, and I don't put these up here for anyone to try and read and learn, I don't even know them by heart. But the ones that you see in red are key areas that are impacted directly by baricitinib and others indirectly that are not shown here. So that gave us the justification for the reverse long COVID trial, which started enrolling earlier this year here in Atlanta, San Francisco, and Nashville, and in Minnesota. And so this study is looking at neurocognitive performance, it's looking at cardiovascular exercise fitness, and it's looking at all these biomarkers of inflammation and sort of markers of aging and functional movement, et cetera. And it's for people who've had long COVID symptoms for 6 months or longer, many of these for several years. We'll be following them over the course of 6 months on treatment and then followed by 6 months afterwards without treatment. These are the sites that I mentioned, including our laboratory collaborators, and this is our central CAB site, of which we're eternally grateful. This is where we are with enrollment. We're on target so far, but we've just heard, and this is somewhat still confidential, I know we're being taped, but the NIH wants to partner with us to accelerate this process. And so we're excited that they're looking for that partnership. This is just showing the complex schedule of activities that we're doing, lots of different tests and blood draws, et cetera, to help us figure out what may be going on in this disease. And this is a report that came out earlier this past year showing 2 patients who were actually physicians themselves who had terrible, basically cardiovascular disease that started right after COVID, wasn't being treated with anything that they did. There were no obvious large vessels. It was all microvessel disease. And they went on baricitinib, both of them, and had, within weeks, had recovery on that, were able to go back to work. So I'd like to end this talk on a little bit of the mind, body, spirit aspects of some of the work that we do. So I think you all are familiar with the Tibetan Buddhist Partnership here at Emory that's been around since the late 1990s. Many years ago, my colleagues, Eugene Farber, who's a psychologist at the Ponce Clinic, and Tad Pace, who used to be here and is now at University of Arizona, were studying some of the results coming out of that program. Various different individual and groups that they studied that went on the program, it was an 8-week program at the time, once a week, I think they were doing it, a couple of hours. They were trained on how to do mindfulness, and in particular, compassion, meditation, and training. It's specific, the compassion piece, and I can talk this if we have time later why, had a reduction in those same inflammatory cytokines. In that not only that reduction was there, but the more that they meditated, meaning they had these journals that they meditated, the lower those reductions happened over time as they continued the meditation. So we said this would be a great thing to look at in our patients with HIV. This was several years ago. And what we found is there was a statistically significant, as you might imagine, improvement in people with HIV. And these were individuals who were virologically suppressed, engaged in the clinic, but they were people who didn't have a good response in their immune system. It turned out they had a reduction in an improvement in their global well-being score and also in their acceptance of their disease state. So it seemed to be more calm in the way that they approach things. And there was a statistically significant improvement in IL-6, tumor necrosis factor, which were 2 key inflammatory cytokines that cause these long-term consequences with HIV. We even found, even though this is a group that's virologically suppressed, we even found in those individuals, once in a while, someone would come off their treatment. They almost approached a statistical significant difference, but it wasn't overall. But you can see numerically almost half the number of those individuals fewer of the individuals on the treatment had virologic failure than those who were not getting the meditation. And it was incredible. A lot of people said, well, you're going to have a problem doing this meditation practice in a population of inner city Atlanta, and people who are poor, have not been exposed to this. They may have religious objections. It was so highly taken up that, in fact, one of the individuals who was in the attention control group, so they both came at the same time every week, and they split on one side of the hallway or the other. The one group went to a kind of mind, body, spirit, health and wellness training education. The other went to the meditation training. That we had a guy twice snuck into the other group, and we ultimately had to withdraw his participation because of the contamination of the study. But there was that much interest and engagement from our patients. So in conclusion, and I should say that I failed to mention, that is being explored. It's actually a grant we've submitted to the NIH now to look at this in long COVID, see if we see the same results. So in conclusion, as I mentioned at the beginning, there's excess non-acute COVID morbidity mortality since 2020. It's been substantial. Many different reasons what may be the cause of this. Healthcare disruptions, long COVID, and stress appear to be key drivers. Stress and social isolation, they increase inflammation and they decrease that cell-mediated immunity, which is critical both to respond to infections as well as to downstream aging. Viral infections like SARS-CoV-2 precipitate and exacerbate those age-related conditions via inflammation and the other situations like changes in the gut microbiome, oxidative stress, etc., as does HIV. Very strong parallels between the two. JAK-STAT inhibition reduces inflammation in senescent cells with proven clinical benefits in acute hospitalized patients with COVID-19. Potentially also, we're hoping to see the same in long COVID and also HIV studies, but we're also looking at CTE, so people who have had traumatic brain injuries during football and other military-associated situations, depression, Down syndrome. So there's a number of different, here at Emory, trials ongoing right now to study this in various domains. Compassion-based meditation improves wellness and inflammation for people with HIV, and is to be studied, as I said, in long COVID. And ultimately, what's absolutely critical, and I hope I've made this point throughout the talk, is engagement with our community is central for us to be effective at what we do. They're involved from the beginning, from the questions that we ask, to the development of our protocols, to the interpretation of the science, and ultimately to the dissemination and implementation, and hope we can keep this model in everything that we do. So huge thanks to all the participants and staff at all of the sites that we work in. Mentioned here, this is some of the individuals who've been there all along the way. And then acknowledgements to the teams in these various clinical trials and studies, not only here in the US, but also around the world in both Barrier and ACT. With that, I will stop, and I don't know if we have time for questions, but I appreciate your attention.
And we definitely have time for questions because we go till 1.
So I was waiting for the slide that drifted into the age-related stuff and all the funding you got for age-related, regression because of your monoclonal antibody. It's still coming then, right?
Yeah, the funding is coming, for the monoclonal antibodies. Yeah, that's the funding situation has been tricky, as you know. I do think one advantage that we've had is aging is relevant across the board. And we found this out almost 23 years ago. Amy Justice, who I think Dr. Gaines is familiar with in the VA system, went to the NIH and said, look, people with HIV are aging more rapidly. This is a very serious problem, as again, the community telling us, right? And they blew her off, right? Very negligently. Turned out she was absolutely right. And, now decades later, it's a second foregone conclusion, right? And the same situation we're seeing now with long COVID. We're realizing now all of these other probably viral infections. In fact, it turns out the Great Pandemic, is a wonderful paper, I'm happy to pass this along, is responsible for 2 different categories of major causes of cardiovascular disease in the subsequent decades, right? Huge impact. There's modeling impact showing where that related. And there's probably various other kinds of situations similar to that are yet to be discovered.
Is there with all the dementia related problems or balance or things of that nature, is there a monoclonal antibody study that addresses cognitive dysfunction or, I mean, you've addressed inflammation throughout is there something that connects this with cognitive decline? And are there studies that are going on where people are putting one arm or the other and getting this treatment so that, and then you follow them to see what the trajectory of their cognitive function is?
Absolutely. So the reverse long COVID study I was talking about is the primary aim is actually cognitive function. So they get baseline CNS vital signs, the ECOG, as it's called, in a number of other batteries of tests, and then we'll follow them in the placebo-controlled fashion. We're also doing this for people with HIV. It's a Berry CNS study. I was fortunate to be a part of this. Unfortunately, we lost the PI he's one of the individuals I showed here during COVID, but we've continued the study on, and that's looking at not only the cognitive impairment with HIV, but also the virus itself being in the CNS and the relationship with that in HIV. And then there are these other studies I mentioned too, depression. This is people with HIV, and there's a separate one without HIV that's just started. That's also looking at the cognitive impairment. So there's a number of these, and that's just our work, but then others around the globe that are doing the same. Absolutely. Yes, sir.
What length of time after an acute COVID infection is required to make a long COVID diagnosis? For example, if it's a year afterwards, those are excluded, or 6 months later, those are excluded?
Yeah, that's a good question. We usually say it's got to have a close temporal relationship with the COVID. So it's typically has started already within 3 months of the diagnosis. So, if you're that far out, and it's unlikely to be related. But most people, it starts almost, immediately. Some people have the loss of smell and taste, for example. I had that for about 12, 14 days. Mine recovered, but that's an example of it's a direct connection to it. And that temporality for at least our trials and for the way that we define it has to be connected. Something starting well beyond after that, it's not likely to be connected. Something else, but not long COVID.
So, there's always been a balance between the immune system dealing with a foreign invader, microorganism, and the immune system doing damage and getting that right. You mentioned in the long COVID that one of the risk factors is never being vaccinated. How does vaccines work into this theory? Because clearly that's activating the immune system, but it seems to help the individual in most circumstances. So how do you fit that in?
That's a great question. And first caveat here to place is that there is such a thing, although I know it's very controversial, and I'm only giving party line on this rather than saying it's my own direct observations or my direct research. But vaccination does have a very small percentage of individuals who will have similar issues to this. So that's the first.
And in my question, I account for that.
Yeah, that's the first thing I will say. So I'm not going to come out here and say vaccines don't do anything and go on and move away, because that creates a lot of the problems that we run into, right? But it's an extremely small number. That's where I think we need to focus on, is scope and scale. So why does it happen in the first place? What's going on with the immune system? The best way I can kind of put this is the precision and targeted nature of that immune response is critical, is everything. And we can talk about, is there enough interferon gamma, and is the targeting of the T cell recognition to the viral epitopes sharp and well-defined? All of those things are critical for that immune response to happen. It's not just I got enough cells, I'm young and healthy. There really is this surgical nature to the immune system.
That's why some vaccines are really good and some are not.
Exactly. And so those people who have this very surgical strike, they go in, they take the virus or the pathogen out, and they walk away, do the best. If instead they kind of fumbling around and, oh, am I getting it? Oh, I'm not getting it. Oh, I'm not getting it. And they're just missing the target, they start creating these problems that we're seeing. Now, that doesn't last forever, and the virus often just kind of goes away. But sometimes that just doesn't stop, and it keeps going for reasons. mimicry is one thing that I don't want to overplay that hand because people use that a lot. And it's only this dysfunctional process of which we're still understanding, even when there's no protein around. You can give a description of, oh, the virus is still there. That's also a small percentage, right? Persistent virus happens. I've reviewed reports for the New England Journal, 375 days of viral replication of SARS-CoV-2. That's crazy. That's very rare. People on heavy immunosuppression that you see that. The vast majority of these people are not even producing any protein. They just keep going, and they've been put off into this problem. Now, some of them, it goes away even on its own. But the ones that really persist, and it turns out, there's a reason why, if people are interested, young women tend to be at much greater risk. It's very interesting. Why are young women at much greater risk of autoimmune conditions as well? So it turns out that women tend to have stronger immune systems than men do. And they actually do better at acute COVID than men do. They clear the virus better, do a much better job. But these persistent activation of the immune system, especially the autoimmune conditions, it's the balance. Yes.
I noticed you mentioned there, it kept popping up on several slides, the APLR complex. And I have been working with sleep patients in narcolepsy, that's tightly associated, thought to be triggering autoimmune.
Yeah.
And that's genetic. And I know that was one of your factors, but you really didn't discuss.
And elaborate on that. Yeah, no, great question. And these inflammatory, so HLA-DR is an expressed protein on the surface of T cells, and it's used by and large of all cells that are expressing proteins from an infection, for example. It expresses this, and then the T cell comes and it recognizes that HLA marker. That's how it gets rid of the pathogen that's there. And there are certain ones that predispose, and we see this in HIV, okay, that there's a certain HLA B5701, there's a number of other ones that predispose you to being able to clear the virus, and there are other ones that don't. We look at it for expression of inflammation. This is a way that we know these cells are activated, that they're responding. So in this case, they are CD38 HLA-DR positive T cells, CD8s and CD4s. When they're overexpressing those, it means inflammation is very high.
And we inherit different ones from our parents, because not all of us have all these HLA markers.
That's exactly right. And in particular, the depression field, so Andy Miller, those of you familiar with, you may have talked here before, has studied this in depression, the same kind of this HLA-DR expression in depression, and probably similar to sort of sleep, is a driver of depression. Is it the only cause of depression? No. But it is a segment of depression why probably we're not hitting the mark when we're using these serotonin agents, et cetera, because that has nothing to do with that group of patients' depression. It's inflammatory.
That's probably the issue with long COVID, which is that it's not one thing.
Exactly. Exactly. Which is why we are, and this, I'm not saying this to give a bleak picture, we're likely to fail repeatedly in our attempts to treat this because of heterogeneity.
Yeah. I've always been convinced that was long COVID. The problem with long COVID had always been, how do you define it?
Exactly.
I think we have some people.
No, it's two things. Stop your screen sharing, as the Zoom people would like to see you better.
Oh, sorry. Why is it showing? Oh, we're not. That's not on. Sorry.
Yeah, much better now. I see better here, but not up there.
Yeah.
Yes.
So I was interested in the several slides where you talk about threat as a sort of source of stress and the consequences of stress, prolonged stress. And I guess I quickly start thinking about that some threats are real and some are perceived. And I suppose there is any number of tools that each of us has at our disposal to sort of mitigate the perceived threat. I mean, I don't think you said it explicitly, but compassion meditation might be one avenue. But it seems like that's sort of low-hanging fruit. So the slide where there's the tree and the roots and all of the different things that can roll up into negative outcomes, it seems like the stress piece is sort of low hanging fruit in that it might be something easy to address personally. But that's maybe easier said than done, I suppose, other than doing things like meditation. I mean, what are your thoughts about this?
Yeah, and it's got a lot, it's a very kind of wrapped together and even sometimes controversial issue too. And I can say in particular with the patient populations we treat. So a lot of the patient populations and the ones that tend to be the most heavily affected, although we're all affected by stress, tend to be people who are poor, people who are discriminated, people who, you know, are coming from underserved populations. And so in the African American community, for example, there's a concept called the John Henry idea of, you know, you just have to keep struggling, but we'll give you tools to help you deal with the struggle. Right? And this is a very difficult thing to kind of work through, right? Because in reality, we should change the situation, the context, right? The threat should be removed if we can. Let's remove the discrimination. Let's remove the stigma. Let's remove the sources of stress, the poor housing, the poor access to care, all of those things we should be working towards, change the policies, change the mistreatment. That being said, in our engagement, again, that's why it's important to engage with community. They also want to have ways to deal with this. And meditation is only one. There are a number of other different ways and strategies to deal with stress, but meditation is one of those. And as you were pointing out, there are actually 3 levels of ways stress come in, right? And it also speaks to stigma and discrimination. One is the actual direct threats, stigma, discrimination, stress that we feel. The other is the perception that gets built also by repeated traumas, right? Sort of almost like what PTSD does. And the third is that by proxy, right? So the people around us, the people in our lives, the situations that we're seeing, we also are connected to that directly too, if that makes sense. And so being able to work at each of those, and what compassion meditation does is it starts first with the individual, is you have to first start by loving yourself, which may seem kind of strange and obvious to everyone. Oh, I love myself. But especially for people who've been heavily traumatized, lots of stress in their life, that's the first piece that is missing. You need to start there. Then you start by teaching people compassion for people they should already have an affinity for, then towards neutral populations that they could care one way or the other, and then to ultimately be able to do that to people they feel threatened by or people they don't like. And through that process, and it's a very difficult thing to go from one to the fourth without going through those steps, but you have this incredible insight that you get towards the end of this that helps you deal better with stressful situations. It doesn't solve the world around you, but it does a lot at least to turn the volume down, and that's what you're trying to do.
One strategy often recommended for decreasing stress is exercise. How does that alter the immune response, or how is it working?
Well, great question, because I do work in exercise too. I don't have time to talk through that. But yeah, so acutely during exercise, actually both things go down. So you can actually have both your immune response. That's why people say if you got a cold, don't go and exercise immediately because you can kind of make it worse. In fact, the only time I had COVID was on a trip to Kenya where I hiked a 10,000 foot mountain for 10 miles and came back and swam another kilometer. And that night I said, oh, my throat feels scratchy. And sure enough, I had COVID. Now, that didn't cause me to get the infection, but I had a couple of days where I was down for a while and again lost my taste and smell. So you do have an acute situation where it does actually bring it, but in the longer term, even within days or so after that, you actually have improvement in immune response and decrease in inflammation. And I think I showed earlier an image where I was talking through the pathway, and I showed those were 2 different side by side because that same situation of acute and chronic stress happens with exercise, the modulation. Yes, sir.
So during the early times of the COVID pandemic and so forth, we had a talk by Professor Emerita of Public Health who talked about the disparities among African American communities in getting COVID. And the concept she talked about was weathering. And I think that was basically another name for this stress, but I think stress induced by the fact of being in a particular environment.
Absolutely. It's a really intriguing story to read about this. And I feel shame on me, I don't remember the name of this researcher, but in the 80s, she came up with this idea of weathering. And she was sort of shamed out of her hypothesis and even her research. And in the last 10, 15 years has been vindicated on this.
Seem to shorten telomeres in that.
Absolutely. And DNA methylation patterns, epigenetic patterns, all of these things have been now proven to show the concept of weathering is absolutely a true thing. In fact, so much greater the impact of those external environmental things than any genetic cause for how racism rather than race leads to exactly the things you're talking about, this weathering concept. Yes.
I'm having maybe a kind of strange thought, okay?
Love those.
Namely, what are the good things that have come out of the pandemic? In other words, is it the case that the COVID pandemic has created a situation where certain things that you've done have really been advanced because you had better control groups, et cetera, than if we had not had the pandemic? And could you talk about that a little bit? The downside and maybe a side that actually put you further ahead than you would have been like 10 years from now if it hadn't been for COVID?
Oh, super difficult question. And I know Bob's laughing.
The good things that come out of war.
Yeah, that's right. It is.
And similarly, yeah, that's the kind of thing that, and it's hard right now on balance, mainly because of the social political challenges that we're going through. And I think in some ways we're paying prices that I never would have imagined as a result of the pandemic. But if I put in a kind of left brain focused response to what you're saying scientifically, we have gained a tremendous amount because of this. I mean, just the overwhelming amount of scientific and intellectual focus on one single condition with, like you said, so many people to be able to look at is unprecedented. I can't think of ever, you ask our historian here.
A little over 100 years ago, we had it. That was it. And we weren't at the scientific basis we are now.
And that's what I was saying, without the technological skill to be able to do all this and the communication and all the things we have now. So all of that and what we've learned about aging, what we've learned about antivirals and immune modulation, platforms that we've set up that we've never had before, and that's shame on us as a scientific community, should have had these things in place, but we have now at the VA, we've got the NIH, got them across the world. Why didn't we have this, right? Does it take a pandemic? Maybe. But we do have them now, and I'm hoping they remain sustained even despite the political challenges now. So I think there's a lot that we have gained. I'm hoping we're learning a little bit about that community part that I'm talking about our ability to communicate also better, right, with people. You know, there's two ends of the extreme. There's being dogmatic, oh, this doesn't work. And then there's the, well, I don't know, right? We need to find a way to talk about what's going on in a way that doesn't dumb down the audience, doesn't sound like we're talking condescending to them, allows room for there to be the uncertainty that is our science, but also brings confidence at the same time. So that's a tough place to be. And I'm not saying I wasn't trained in that, right?
Sure.
But we do need to do that better moving forward. So who knows? There's a lot that we're learning. Like I said, I hope that question 10 years from now turns out even better than what I'm seeing right now.
Yeah.
Thank you.
Yes.
So a simple question, it would seem, would be what percent of people who get COVID get long COVID? And that seems to be actually a fairly complicated question. I mean, even, a question would be, okay, if I'm vaccinated, how does that change my chance of getting long COVID? And I've done a lot of reading, but it seems like even questions like that are hard. And of course, from what you said, it really depends a lot on the person and how they respond and so forth. But how do you answer a question like that?
Yeah, I mean, I kind of showed earlier that at least one symptom of long COVID, again, that's not the classic condition, but one symptom is about 40% of all people who get COVID. I would be one of those, right? So well after I recovered, I was fine, was going back to work, doing everything. I couldn't taste or smell any, like zero. It's much more impactful in my life than I thought it would be. And for those of you who've had it, you realize it. I would have beforehand, I was like, what's the big deal? It kind of sucks. I had that for 14 days again. It's not even that long. I would be in that 14%, 40%, right? So that's not that severe. However, for those having the full-fledged thing, about 10%, can be upwards of 15 to 20, depending on the study that you look at. And the debilitating, this is like the patients I presented, about 5% of all people get long COVID will have that. Again, that's general populations. It's higher, as I mentioned, in those specific groups that we talked about. But in the general population, those are the numbers we have. So when you're weighing the vaccine versus not the vaccine, that absolutely has to be the calculus. It hasn't traditionally been in there in those discussions, but really should be.
So what is the effect of being vaccinated then?
Yeah, so when the study that originally looked at this found it was a 20% rate in people who were unvaccinated, it went to 2 or 3%, something like this amongst the vaccinated. Yes, sir.
Is that ever vaccinated or people, do we have to keep on getting vaccinated and vaccinated and vaccinated to get to that 2% versus, you know?
This was just initial vaccination. And, some of those people did have additional ones, but it wasn't like repeated vaccine was required to get to that 2 to 3%. I have to look at the number of repeat vaccines, what population made that up, but it was just having a full vaccine series.
And then would repeat vaccine, I guess this hasn't been studied, but I wonder if you just keep on getting let's say if you're over 65 and you get them every 6 months or whatever, would that
Reduce it even further?
Yeah.
Question. I mean, it's hard to imagine getting a whole lot lower than the 2 to 3%. I mean, you probably could go a little bit lower, but I don't know of the data. I don't know, Bob.
I don't know of the data for that in particular, but for almost everything else, getting it every 6 months is better.
Yeah, for
So
just the
I
death
would
and-
think
yeah.
that might go along with it, but yeah.
Yeah, for dying acutely, for, getting
I mean,
hospitalized.
just about everything else, it's better.
And now that the federal government not recommending COVID vaccines for people under 65 unless they're immunosuppressed, it's almost conceivable that there could be sort of an increased epidemic of long COVID with if the younger people are.
I mean, if this persists as an ongoing infection, right? And as we sort of move away from this mass vaccination that we had in the beginning, absolutely, it's conceivable it's going to go up, right? You're going to have an unvaccinated population getting it, right? As they move forward.
People over 65, they're actually up to date on COVID vaccine is quite small. It's astoundingly small.
No, it's not that great. It's a situation where I think your comment is a good one, except young people are still allowed to get the initial series, and that may mitigate some of this. But unfortunately, I think the current view of vaccination is not being encouraged in general. And I think your point is more on that, I think, than the fact that you can't get a booster if you're under 65 and not immunosuppressed, or at least you have to pay for it yourself.
It's not being encouraged that much
Yeah.
among those
But
that
that's-
are over 65.
Yeah, I think the message, and that's the key point.
That's really the
It's the
point.
message came out almost like, don't worry about this. Unless you're over 60, just don't worry. And that's not really what it says, but that's, I think, the message.
So that's the message in general that we're seeing with vaccinations right now. And I think we have a just collective amnesia about how bad things were before we had all these vaccine preventable diseases prevented. And, measles, I can just go on
Measles is just nuts.
about all this. It's maddening and sad.
And yet those of us that work in healthcare have been titered for measles, have been titered for hepatitis, a whole bunch of them. It's just what we did.
Right,
Mm.
right. Great. Anything online?
Okay.
Just, so what impact has this had or will be having on medical school training?
That's a very good.
Yeah, it's a good question.
Public health and nursing, because all three of us
Okay,
have.
well, I mean, broaden the question, sure.
Excellent question.
Yeah, I mean, I can't speak to what's changed in the curriculum, to be honest with you. I'm not directly involved in some of those decisions, but I do work with, people like Michelle Lample, who's in the Center for Human Health at the undergrad level and also at the School of Public Health. And it's absolutely being included in those seminars. So I know the training is bringing long COVID and the concepts of long COVID and aging more front and center. I mean, that's this kind of a talk I'm giving Michelle. If those of you not familiar with Michelle Lample, she's trying to change the way that people do medical education in general and has done it already here, but not to have everything be focused on medicalization of disease, but earlier kind of management of the upstream predictors and risk factors. So this fits in with that concept, right? Is trying to maintain a healthier population that, like vaccinations, like, good nutrition, low stress, all of the key things that,
And they also talk heavily in the School of Nursing at all levels about social determinants of health, which hits the racism, poverty, stigma.
This was great. Thank you all again. Really enjoyed it.